Thank you, Dr. Lin. That was a great presentation. And so with that, I will be starting talking to about my presentation for healthcare disparities in gastrointestinal cancer. I'm one of the medical oncologists at Moffitt Cancer Center, and I'm mainly focused on colorectal and pancreatic cancer. So healthcare disparities are actually well defined by the CDC at this time. It's well recognized problem in the United States. Healthcare disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by social disadvantaged populations. And there are several underlying reasons for that, and just to recap a couple of them, and one of the most well-known, well-established reason for that is poverty and financial disparities and the distribution of the wealth among the subgroups of society. Inadequate access to healthcare, regardless of the financial status, able to achieve optimal healthcare remains to be challenged. And there are several factors that for that problem as well. And in addition to that, individual factors plays a role in that too, and person's behavioral choices and factors that comes to play in healthcare disparity. And unfortunately, one of the underlying sociological problem is education inequalities results into unfortunately ineffective healthcare screening and ineffective access to healthcare in the United States. So this is just a brief introduction for kind of overall perspective to the different type of cancers, but this is mostly focusing on colorectal. As we see over starting early 90s, the difference, this blue line up on the left figure showing the Black community, and the white green line on the bottom showing is the white population. And unfortunately, although colorectal cancer has screening models reduce the rates of the colorectal cancer in the United States, the gap between the black society and white society has never really actually closed, and the gap within current 21st century still remains there. And the right is another database that was evaluated and assessed, and this is a SEER incidence rate in the United States between 1975 to 2013. Again, it clearly demonstrates, again, just to make it clear, the green line on the top is Black community, representing Black community, and brown on the bottom is basically all races, and the blue that actually crosses that line is the white population. As we see over the 2 to 3 decades, the gap in the colorectal cancer incidence rate is there, and then perhaps actually softening up. So that's quite concerning that unfortunately the African American and Black communities being more affected by the colorectal cancer. And as we know, Black Panther event, Mr. Chadwick unfortunately had a colorectal cancer in an early age, and that's also created a significant recognition of this the main problem in our society. And this data that I'm presenting is actually basically summarizing and also demonstrating this big challenge. So that is a figure that shows different type of gastrointestinal cancer that we treat, and I want to just highlight a couple of them. For example, gastric cancer. So interestingly, the incidence is higher in Black community as compared to white community, but more importantly, that it's not only the incidence rate, but also the mortality rate, meaning that how highly mortal that disease in that subgroup. So it's although the incidence rate is higher, but the more dramatic increase is actually in the mortality rate. That's true for gastric cancers, stomach cancer, same for colorectal cancer, and even more interestingly, in anal cancer, we see the frequency, the incidence rate is less in the in the Black community, but again, the mortality rate is high, although the incidence is lower. So that's quite concerning. It's not only screening models, but also accessing the treatments is a big challenge. So this is a figure demonstrating it's a very comprehensive database published in Cancer Facts and Figures, showing basically last 3 decades, almost 3 decades. And the left one is basically showing the male population, and the right figure is showing the female population. And again, regardless of the gender, as we see, this is for all cancers, and there is a gap, and the gap unfortunately is existing regardless of the gender for both male and female. And the black line in the bottom, the upper black line is showing the African American or Black community, and the bottom is showing the white community. That the problem is real, and it's a comprehensive and large problem existing in all types of community. And this figure is actually very interesting that I find, for example, colorectal cancer. If you go early 1970s, that the colorectal cancer incidence was higher and mortality rate was also higher in white community. But that started to change in the late 80s, and the line crossed the black lines, demonstrating the African American and Black community. That unfortunately showing that the gap started to open in late 80s and early 90s and never closed, even though screening models has reduced the incidence in the subgroup, but the gap never closed, indicating the screening models and also the accessing to the care for colon cancer, which is one of the most common type of gastrointestinal cancer, never been actually same for subgroups of society. And there are also, although it's not my topic today, the problem is existing also gender-specific tumors, for example, prostate and breast cancer. As we see, there's dramatic differences in the incidence and mortality rates. So that's not actually, the problem is not unique to colorectal cancer. As I mentioned, it's a broad spectrum challenge, broad disease type. For example, this study is published by Astorop and Friends in the Gastroenterology Journal. As we see here, the early stage localized gastrointestinal cancer, esophageal cancer, the mortality rate is 22%. In 5-year survival rate, is 22%, and this is 44% for white population, meaning that almost double, survival rates in white population as compared to Black, and this is highly concerning. And similar, problem exists in the regional disease. For even you detected early cancer in African American, the mortality rate remains high. That indicates the problem is not only relying on the screenings and catching the disease early, but also after that, how accessible to treatment options. And unfortunately, just a couple examples how that happens. Sometimes patient incidentally comes to ER, being detected with early cancer disease and being discharged for continuation of the care in an outpatient setting. And that generally, unfortunately, doesn't happen, and the patient gets lost easily. And that happens more often in the Black community than the white population. And again, this is multi-layer problem, and not having health insurance, because we don't have a social basic healthcare system in the United States. The patient cannot access the outpatient setting, and that's again very dramatic and very unfortunate. That even early stage cancer has different outcomes in different racial subgroup of society. So this is kind of a very general and summarizing figure that clearly shows an overall cancer type that, by the way, the lines, that dashed lines are showing the black community, and then straight lines are showing the white population. In overall cancer type, as we see, there's more quick, unfortunately, drop in the dash line, which is indicating higher mortality rate in African American and Black community in the United States for overall gastrointestinal cancer. And the problem is again existing in colorectal cancer. And nowadays, the pancreatic cancer is a big challenging gastrointestinal cancer. And the problem was actually more common problem in the white community. But nowadays we see actually this challenge, this started to be bigger challenge in more African American, and the curves are separating and higher mortality rates in African American again. So basically, the challenge is there. The problem is access to healthcare and utilization of available screening problem, and that's the key. How we can make that difference in our Black community. This is an paragraph from Cancer Facts and Figures for African Americans in 2016 to 18. So prior to 1989, incidence rates were predominantly higher in white men than in Black men, and were similar for women of both races. And since 1989, however, the incidence rates have been higher for blacks than whites in both genders. This crossover may reflect racial differences in trends of risk factors for colorectal cancer and or greater access and utilization by whites. And that's where the problem starts, accessing the healthcare and utilization of available screening models. And even after that, accessing the cancer treatment, which I'll be coming later on. So this is the problem is not only is a racial problem, it's also for other subgroup of society. For example, having a coexisting diseases that remains a big challenge in the United States. So this is a study by Heisel et al. Published in Open Forum for Infectious Disease. As we see in HIV-infected populations, screening for breast cancer and cervical cancer is a lot less than for patient population who are not having HIV disease. This is quite similar for colorectal cancer, so this is actually good. But I'm going to come to another data that recently published in the JCO 2014, which is the official journal of American Society of Clinical Oncology. Very unfortunately, the treatment, access to treatment or having a treatment for the cancer is almost doubled, unfortunately, for colorectal cancer. As we see, 14% of the HIV-infected patient population with the colorectal cancer can never get any treatment for their cancer, versus that's only 7% for overall population. And someone would suggest that's actually a problem of the past, but it's not actually. As we see on the right side, the analysis of the 2006 to 2010, the problem still remains as it is, and the untreated colorectal cancer among HIV-infected patient population is 16%, versus that is 8% in HIV uninfected patient population. So that's actually quite concerning, and this problem is not in GI cancer only. I highlighted some other disease too, but my focus is called GI today, GI cancer. So this is a very challenging situation for HIV-infected patient population in the United States. So the problem is, in that regard, is not only related to the healthcare system, but also partially due to our judgments as a physicians too. Someone may ask why. Here is one of the publication by Aldrich et al., JCO 2017. So look, this figure demonstrating clinical trials enrolling patient who has an HIV. The gray part of the bar, the round figure is basically demonstrating people who are having HIV, and they are almost 65 of the overall, probably 80 trials excluded patient who has an HIV in their trials. And nine of them partially excluded them, and only 7 trials include the HIV-infected patients. So that means we are in fact excluding a lot of HIV-infected patients who are living with HIV from trials where the treatments emerge and more promising treatments comes into play. That's highly concerning that how we judge the patients regardless of evidence. And that sparked a lot of attention actually. And ASCO and Friends for Cancer Research HIV working group created guidelines for that not to exclude patients for HIV with an HIV just because of their disease, or rather having a rationale to algorithm to include them in the trials, because this is basically labeling, unfortunately, just because of their disease and excluding from the trials. Now, based on these guidelines, these recommendations, including almost all HIV patients with CD4 count above 350, regardless of their underlying HIV disease, unless there's another reason for exclusion. And even for the patient who has lower CD4 counts, there are opportunities. For example, there are trials that may not have impact on the immune system, and if the patient never had an AIDS-defining disease or opportunistic infection, the consideration should be still in place, including those HIV patients. And even for the patient who had an AIDS-defining infection in the past, it may not be so relevant if that happened, 10 years ago, and if the patient has really well-controlled HIV right now. So the emphasis of this recommendation: be inclusive as much as you can. Do not judge or do not label the patient because of their disease that may not have much to do with the treatment, and maybe it's very well controlled and doesn't have an impact on the outcomes. So now we are understanding and recognizing there are several types of disparities. So, and another one is actually not that well recognized still as a challenge is age group of patients that we treat in cancer, and that includes gastrointestinal, but for children especially, that we see more probably other types of cancer that unfortunately the trials are not including because of the concerns. So there are very promising trials comes in early stage trials, in the early stage studies, and unfortunately children are excluded exclusively from these trials. And now the recognition that's a problem because we are preventing those potentially beneficial treatments to be accessible for children. Now that recognition came to place, and we are understanding that we need to be also more comprehensive for different age groups. This is not only unique to the children, but also for elderlies, because one of the criteria that I always look into is ECOG performance status and underlying medical conditions and adequate organ function, which are more common problems in elderlies, and especially in gastrointestinal cancer, which happens to happen more in elderly population, indicating that we need to understand that the criteria should be fair for all part of the society and shouldn't be excluding people who are having other medical conditions as well. So with that, I would like to conclude my presentation. In brief, I would like to indicate that we have a multi-layer problem, and the multi-layer problem requires multi-layer working groups that includes changing the healthcare system to education of the society and education of the communities, how we can make the healthcare system more accessible and to the subgroup of society who are underrepresented and who are unfortunately affected more with these disparities. I personally feel, this is my personal feeling, healthcare is an human right, and everyone living in the world should have equal access to the healthcare system, no matter what subgroup of the society they belong to. With that, I would like to conclude. Thank you so much for this opportunity.